Hi, I'm Jade, and I'm a final year medical student at the University of Leicester. In today's video, I'll cover some important differential diagnoses for the presenting complaint, tired all the time. Imagine you have a 64-year-old lady that presents to her GP with excessive tiredness for the last 4 weeks. Pause the video now and try to think of some differential diagnoses that you would want to consider when taking your history and doing your examination. Some differential diagnoses to consider include anemia, depression, hypothyroidism, obstructive sleep apnea syndrome, and Cushings syndrome. Let's go into a bit more detail for these conditions, starting with anemia. Anemia is defined as hemoglobin levels which are 2 standard deviations below the normal for one's age and gender. In adult men, this means a hemoglobin of less than 130 grams per litre, and in adult women, this means a hemoglobin of less than 120 grams per litre. As red blood cells are responsible for carrying oxygen around in the blood, low levels of hemoglobin and thus red blood cells means less oxygen is carried around in the blood and aerobic respiration is reduced. Energy levels will therefore be reduced and patients will present with tiredness, pallor, headache, dysopnea, and on examination they may have tachycardia, atrophic glossitis, and signs of the underlying cause of the anemia such as cachexia. Anemia can either be microcytic, normocytic, or macrocytic, depending on the mean cell volume. Macrocytic anemia can be caused by pregnancy, alcohol excess, hypothyroidism, reticulocytosis, B12 or folate deficiency, or cirrhosis. B12 deficiency may be due to a reduced dietary intake, for example in vegans and alcoholism, or an autoimmune condition affecting the gastric mucosa that causes reduced B12 absorption. This is called pernicious anemia. Celiac disease is an autoimmune condition caused by sensitivity to gluten that causes villus atrophy and malabsorption, and that is another cause of B12 and folate deficiency. Causes of normocytic anemia include acute blood loss, bone marrow failure, chronic disease, and destruction, for example by a prosthetic heart valve. Causes of microcytic anemia include thalassemias, chronic disease, iron deficiency, and lead poisoning. The thalassemias are a group of genetic conditions characterized by reduced production of either alpha or beta hemoglobin chains. Some basic investigations you may want to request for the lady in this case to look for potential anemia include FBCs as well as B12, folate, and ferritin levels. You may consider requesting LFTs if you're suspicious of cirrhosis or alcohol excess being the cause of the anemia. Ferritin will be low in iron deficiency. If B12 is low, you may request serum anti-intrinsic factor antibodies. If folate is low, consider doing anti-TTG antibodies to investigate for celiac disease. Any person over 60 with iron deficiency anemia must be referred via the 2-week wait pathway for colonoscopy for suspected colorectal cancer. Any woman with iron deficiency anemia should be asked about menorrhagia and postmenopausal bleeding if applicable. Management of anemia depends on the cause and the severity of the symptoms, as well as the hemoglobin level. A 3-month course of oral ferrous sulfate is usually used to treat iron deficiency anemia. In folate deficiency, folic acid tablets can be supplied, as well as advice on how to increase folate intake. B12 deficiency persisting despite increased dietary intake should be treated with IM B12 injections 3 times a week for 2 weeks, and then maintenance injections 3 monthly. A transfusion of red cells can be considered for symptomatic anemia when the hemoglobin is less than 70. Next, let's talk about depression. Depression is another important differential diagnosis for this presenting complaint. In the history, you want to ask about the core symptoms of depression as well as the associated symptoms. Pause the video now and try to remember them. The core symptoms of depression are low mood, anergia, and anhedonia. Other symptoms and signs include early morning wakening, reduced appetite, reduced concentration, weight loss, and thoughts of self-harm and/or suicide. If you are suspicious of depression, then you must do a risk assessment. You need to assess the risk of suicide and also consider safeguarding for the patient and those in the patient's care. The key investigation used in the diagnosis of depression is the PHQ-9 questionnaire. Mild to moderate depression is treated with lifestyle management and self-help, including trying to exercise for at least an hour per day, making sure to eat regular meals, and having good sleep hygiene. CBT, mindfulness, and counselling should also be recommended. For severe depression, consider treatment with antidepressants. SSRIs like sertraline are first line and continued for at least 6 months after the episode of depression. On initiation of SSRIs, you should advise the patient that the tablets can take up to 6 weeks to have an effect, and the risk of suicide is increased in the first few weeks. Fluoxetine is the SSRI of choice in young adults under 18. SNRIs or mirtazapine can also be considered if SSRIs are ineffective. Mirtazapine is used for treatment-resistant depression and is especially helpful if the patient struggles with sleep, due to a main side effect being drowsiness. However, it's also associated with weight gain. Next, let's consider hypothyroidism. Hypothyroidism is associated with Down syndrome, Turner syndrome, and autoimmune conditions, including celiac disease. The most common cause of hypothyroidism in the UK is Hashimoto's thyroiditis, which is an autoimmune condition where antithyroid peroxidase and antithyroglobulin antibodies are produced and they attack the thyroid gland. Other causes of hypothyroidism include de Quervain's thyroiditis, childbirth, low dietary iodine intake, and iatrogenic due to the use of lithium, amiodarone, carbimazole, or irradiation of the thyroid gland, for example, in whole-body irradiation to treat ALL. Other symptoms of hypothyroidism include weight gain, cold intolerance, dry skin and hair, constipation, menorrhagia, carpal tunnel syndrome, and potentially a goiter, for example in Hashimoto's. TFTs are done for suspected hypothyroidism, and if there is high TSH and low T4, this is diagnostic. Hypothyroidism is managed by replacing T4 with levothyroxine. The starting dose tends to be between 50 and 100 micrograms once daily, and it must be taken in the morning at least half an hour before breakfast. TFTs should be checked after 8 to 12 weeks of changing the dose. The levothyroxine dose should be increased by 25 to 50 micrograms if a woman becomes pregnant. De Quervain's thyroiditis is self-limiting and does not require treatment, besides analgesia if required. The next differential we'll consider is obstructive sleep apnea syndrome. Obstructive sleep apnea syndrome is where there is intermittent collapse of the pharyngeal airway during sleep, causing episodes of apnea terminated by partial arousal. This fragmented sleep causes the patient to wake up unrefreshed and be excessively tired throughout the day. Their partner may have witnessed apneas. Patients are often obese and may have noisy breathing. In the history, you must inquire about smoking, family history of OSA, weight gain, and use of alcohol and sedatives. Rule out differentials for OSA like heart failure, COPD, and enlarged tonsils. The Epworth Sleepiness Questionnaire is used as a tool for investigation and to help dictate whether or not the patient should be referred to the sleep center for diagnosis and treatment of OSA. Polysomnography is done in these specialist centers, and the treatment options include mandibular advancement devices, CPAP during the night, and potentially surgical removal of any airway obstruction. Lifestyle management options include reducing weight, smoking cessation, and reducing alcohol intake. If there is a high clinical suspicion of OSA or after diagnosis, the patient must inform the DVLA. The last differential we will consider in this video is Cushing's syndrome. Cushing's syndrome is a collection of features caused by prolonged exposure to high levels of glucocorticoids. It can be subclassified as either ACTH dependent, where the ACTH levels are high, for example in small cell lung cancer and Cushing's disease, which is where an ACTH releasing pituitary tumor causes hyperplasia of the adrenal glands, or ACTH independent, where ACTH levels are low, for example due to exogenous steroids or an adrenal cancer. Normally, CRH is released by the hypothalamus, which stimulates the ACTH release from the pituitary gland, which in turn causes cortisol and androgen release from the adrenal gland. Some symptoms and signs of Cushing's syndrome are weight gain, depression, amenorrhea, erectile dysfunction, buffalo hump, moon face, bruising, acne, recurrent infections, and abdominal striae. In small cell lung cancer, there'll also be hemoptysis, a cough, B symptoms, and possibly pigmentation. Cushing's syndrome is confirmed with a dexamethasone suppression test and 24-hour urinary free cortisol levels. A low-dose dexamethasone suppression test is done initially, and if there is no suppression of cortisol, then this confirms that there is Cushing's syndrome. To identify the cause of the Cushing's syndrome, then the high-dose test is done. If cortisol is suppressed with 8 mg of dexamethasone, then Cushing's disease is the most likely diagnosis. If cortisol remains high and ACTH is low, an adrenal tumour is the likely cause, and if ACTH is high, then consider causes of ectopic ACTH release, such as small cell lung cancer. A chest X-ray should be done to investigate further for this. Management depends on the cause, but it may involve reducing steroid dose or gradually withdrawing any steroid treatment, surgery, chemotherapy, or radiotherapy. Thanks for watching!